Thank you, and thank you for the kind words. It's humbling. Um, what today we're going to do is we're going to finish up with the ethical concerns from last week, but I wanted to show you that what we have gone through so far. We've gone through all of these processes. We're on the very end of making difficult decisions, and we're going to talk in addition about placement and life after today. So I'd like to go to ethical issues. And if you'll remember in the hard decisions, we talked about decisions about driving, about traveling, about tools and shops, and talking about entertainment and sex and a few other things. This was the last section we didn't quite get to last time. And so I'd just kind of like to go through it. I'll probably go through it a little quicker because we have to get to the placement and the life after on this. There are ethical decisions that you will be facing as a result of the advanced directive and the progression of the disease. I didn't realize it at the time, but you definitely are. And in retrospect, you make decisions and you don't realize that it's really in the ethical realm. What are some of these decisions? Some of these decisions are, do I faithfully implement the advanced directive of the care receiver? Do I permit the assisted feeding of the care receiver when they can no longer feed themselves? Do I advocate VSA, voluntary stop eating and drinking, for the care receiver? Do I stop prolonging, life-prolonging medications such as statins and Aricept when they are placed in a memory care facility or when they enter middle or late stages of the disease? Do I keep detrimental foods, snacks, or candies from diabetics and others with dietary restrictions when they enter later stages of the disease? Do I violate my vows by placing them in a memory care facility? Do I or can I date while they're in a memory care facility? What do I mean when I say fully implement the advanced directive? If you've been designated the agent for the care receiver, you must fully understand the wishes of the care receiver when it comes to the provisions of the advanced directive. I have included Nora's advanced directive as an example. It does not matter if I disagree with her choices or wishes. I, as her agent, must speak for her and her wishes. If you cannot speak for the care receiver and their wishes because of ethical conflicts with your own beliefs and moral code, then you must not be their agent. It will be a violation of the advanced directive. For example, a care receiver does not have to have a feeding tube. It does not want a feeding tube, but their spouse, their agent, believes in a feeding tube. If the issue of not eating presents itself, then the spouse agent will have to speak for the care receiver and not let the medical staff provide the tube feeding, even though the agent believes in tube feeding and would want the care receiver to live as long as possible. In my experience, Nora indicated in her advanced directive that I do not choose to prolong life. This guided my voicing of Nora's wishes when it came to the above ethical issues and decisions. I placed her so that she would get better care than I could provide. The placement also enabled me to better manage her care, especially when it comes to the following issues: to not provide her statins, anti-cholesterol, and Aricept, which slows the pace of Alzheimer's disease, medications that I determined extended her life and consequently went against I do not choose to prolong life. I continued her thyroid medicine as I determined this was a comfort medicine, not a medication that would prolong life. I also felt that she should not spoon feed if she could not feed herself. I gave the instructions to offer her food. However, if she could not or did not eat, then that met her advanced directive. I was able to convey these and other of Nora's wishes to the staff of the memory care facility and to the doctor who visited the memory care facility weekly and to hospice. They all supported Nora's wishes. I did notice that after 2 rounds of hospice that the facility was assisting in feeding Nora rather than letting her have finger food. This came about because an ombudsman requested that Nora be provided with 3 nutritious meals, and if she's unable to feed herself, provide assistance in feeding. She regained some weight and was dropped from hospice. We went through this twice. I went to my lawyer and we engaged in the court hearing to request that they stop spoon feeding her. The upshot was that at the hearing, we were confronted with the Oregon administrative rule that required institutions, like the Memory Care Center, provide 3 meals and assist in feeding if the person was unable to do so. The judge completely concurred with the understanding that Nora did not want to be spoon-fed, but she did not overturn the administrative rule, and so we lost. The facility continued to spoon-feed her. This extended her life, contrary to the advance directive, to experience the full gamut of Alzheimer's disease, a process that took another 15 months after the court's decision. The important point here is that I followed Nora's advance directive and did not feel any remorse or guilt in going to court to challenge the ombudsman and the Oregon administrative rule. This hearing became a cause célèbre, and I'm not going to go into all the details because you can read it when you get the PowerPoint on this, but it went to the press. It was in USA Today, it was in the Washington Post, it was in the Medford Tribune, a local newspaper here. And we lobbied the state legislature of Oregon to primarily say that the advance directive supersedes the administrative rule when they're in conflict. As mentioned before, an attorney from Minnesota contacted me. He was going to give a speech in Seattle, and he wanted to know if he could use Nora as an example, and I said, sure, go ahead. I also discussed with hospice Nora's wishes in the advance directive concerning pain. She had indicated, I direct that treatment for the alleviation of pain and discomfort and be provided at all times, even if it hastens my death. I noticed that Nora was restless and exhibited what I took to be discomfort and pain, even though she could not verbally communicate it or articulate what the issues were. I worked with hospice to provide the pain medicine, morphine, to Nora more frequently than was scheduled. I even suggested that they provide larger doses than what would be considered safe. However, they refused the larger doses, but they did increase the frequency of that. My agent is authorized to request aggressive medical therapy be instituted or discontinued, renal dialysis, parenteral feeding, the use of respirators and ventilators, blood transfusions, nasogastric tube use, intravenous feeding, endotracheal tube use, etc. We took parenteral feeding to be spoon feeding. The court indicated that parenteral feeding was really parenteral feeding, which is the intravenous administration of nutrients. The state of California removed this from the advance directive in its next edition because of the confusion. The reason I'm including the advance directive of Nora is to show that major ethical issues are derived from the advance directive. How the maker of the directive wants to be treated when they cannot feed themselves regardless of the reason. The use of prolonging medicines when the disease enters its later stages. Remaining in the home rather than placement. If placement in the least restrictive home-like environment, and the use of pain medications which may shorten my life. This is the example that I'm talking about, and you'll see it when we submit and you get the PowerPoint. The orange arrows are the areas that I pinpointed to basically guide me in the process of implementing the advance directive. The agent's authority, and when the agent's authority recommendation become effective. Nora initialed this portion of the advance directive. I choose not to prolong life. Also, no restrictions in relation to this. She initialed on this. Again, this is California's advance directive. It's been there have been later additions which are more clarifying in terms of some of these conditions that we've talked about. It says here, I wish to live in my home for as long as possible or reasonably possible without endangering my physical or mental health and safety, and life-prolonging procedures. My agent is authorized to request the aggressive medical therapy be instituted or discontinued, including but not limited to cardiopulmonary resuscitation and so forth on that. So this was what I used as the basis for getting through these ethical decisions and not to feel guilty about them and not to feel bad about them. Additional ethical issues. This is not an exhaustive list, and there are additional ones. The care receiver may wish to die at home rather than in a facility. Your ethical issue here is, what is your desire? You've been in mourning for years. The care receiver does not recognize you or mistakes you for someone else. The care receiver is not able to communicate or even understand where they are or the environment they're in. So the question is, do you bring them home for the passing or let them pass in a facility? My recommendation is to do what reduces your stress. If letting them pass in a facility is more comfortable for you and reduces your stress, then do it. If you must follow their wishes, then be as simple as possible. Remember, what you do at home is for you, not for the care receiver, as they will not understand their surroundings, nor be able to verbally communicate with family or friends. You will have to work with hospice as the end approaches, as the nurse will be administering morphine and sedatives to calm the care receiver, and you will have to work with the mortuary to come and remove the person from the home. I let Nora pass in the facility. I know this seems to contradict the advance directive and seems to contradict the statement that we have to follow their wishes. The problem is that with dementia, most advance directives do not understand dementia. But I had a friend who had diabetes, and she came home to pass in her home, and we went and visited her. The main difference was that she, even though her body was failing her, her mind was sharp, her mind was good. And so we could talk, we could converse. She understood what was happening. She knew who the people were. She knew what was going on and so forth. And that is a very different experience than a person who is in the very last stages of dementia, where they don't really know where they are. They don't really know who is with them. And again, like I mentioned in the past, the thing that amazed me about Nora was that she had no history and no future. She was only in the present, and she didn't fully understand the present. She couldn't communicate, she couldn't talk. And so bringing her home would have meant nothing to, in my view, would have meant nothing to her. And because she was in the facility for 3 to 4 years, home would have been nothing like, she couldn't even have remembered home in relation to it. So for me, it was better for me if I let her pass in the facility. I watched the whole process without having to call or communicate with the mortuary or mortician, and I did not have to wash the body. I did not know how to do this. The passing was a great relief for me and Nora. The less involvement from me, the better I felt in relation to it. Those are some of the difficult issues that you're going to deal with in terms of the ethical issues. And again, it's in the section that we dealt with, which is hard decisions. Are there any questions or comments?
Yes, there is a question from Luis. Did you have any backlash from family or friends about instituting the advanced directive, specifically the spoon feeding?
No, actually, they were all very supportive. In fact, some of her friends of 30 years testified in the court hearing to the effect that she did not want to be spoon-fed on that. They were all extremely supportive because they understood what she really wanted, and they knew that I wasn't speaking for myself, that I was really speaking for her. I know that in some cases that may not be the case, but again, the advanced directive in a way is the document that you can point to and the document that you can use to say, I'm doing what he or she wanted me to do, and to deal with those issues of where people say, well, that's not what should be happening.
Okay, thank you.
Okay, placement and life after. What do I mean by becoming a guardian? One of the things I found as I visited Nora was that very quickly I ceased to be a spouse. And we didn't really have conversations, and we didn't really talk about things. It was more of a situation where I would say, how are you doing? I'm fine. I want to go home. I don't like these people, and so on and so forth in relation to it. What I became was a guardian. I would come in and make sure that she was clean, to make sure that she was being taken care of, to make sure she was not abused, to make sure that she had all of the things that she needed in terms of clothes or medication and so forth. And so I spent not a major portion, but I would say 1/3 of the time when I would come to visit, I would actually spend it talking to the caregivers and talking to the caregivers about how is she doing, what were the issues, what happened, anything that I need to know or anything that I need to do in relation to it. So as the person enters the late stages, if you go back to our plateaus, you're talking about late stage 6, stage 7 on that. You're really a guardian. You're really just making sure that the person is safe, that the person is being taken care of, and that he or she is not being abused on this. And that's a hard thing. That is very difficult, because when I would enter the room, she would smile, and I thought, oh, she recognizes me. And then I noticed that when a caregiver would enter the room, she would give the exact same reaction to it. Or if another person came into the room who she may not have even known, she would basically react the same way. So she really didn't know who I was in relation to visiting her. So I was a guardian. I wasn't her spouse anymore. And the therapist tried to work with me on understanding that that's what's happening, and that's where I, as a caregiver, am at. I'm a guardian, not a spouse in the relationship. When you get ready to place, there's guilt. There's a lot of guilt in terms of placing it. One of the reasons for the guilt, if you're a spouse or if you're a parent or a child, one is guilt over the wedding vows or commitments made. For example, I attended a wedding this weekend, and these words were in the ceremony: till death do us part, and in sickness and in health, on that. And the thought struck me when I listened to this, that the wedding vows do not take into account dementia on that. The vow to a partner, to a son or a daughter, or to a mother or father: I promise that I will take care of you. These commitments are interpreted by some caregivers as, I must take care of them at home and by myself. I am not meeting my vows or commitments if I place them. It means that I do not love them enough, or I am rejecting them. It makes me feel heartless or cruel. I'm locking them up. Be aware that that is the feeling, not the objective situation. The objective situation is their demand for care is outstripping your capability of meeting it. In other words, you're not providing them with the best care. You're not providing them with the care they need, but you feel guilty about it because of these reasons. Second is the guilt over placing them in a secure facility. As it was stated in a support group one time, it's like sending them to prison. You think that placing your loved one in a secure lockdown memory care center is selfish and cruel. It is depressing when I take a tour, and I would not want to be put in here. Friends and family will think that I'm selfish, uncaring, or heartless. The statement, "I would not want to be here," is projection on your part because you don't have dementia. You're a caregiver. And of course, if you are healthy and normal and don't have dementia, who wants to be in a room full of people with dementia in various stages of the disease? That's not a pleasant surrounding. So when you think about it, you have to think about it in a sense from their perspective, not from your perspective, just like the advanced directive. I found that Nora actually brightened up when I placed her because she was with people who were in the same situation that she was in. When she was home, she was socially isolated. She had very little contact with people. When I placed her, she was in a facility that in effect, lots of people were there. They could talk, they could walk together, they could do things together, some of the activities and so forth. It was a social setting for them. It was a much better place for them than my home or where my home was on that. And I had to overcome the idea of the depression in taking the tour, because when you go into these places, you see people sitting on couches with their head almost in their lap. You see people that look like they're overdrugged and so forth. The truth is, that's the last stages of the disease. That's how they look when they're in the very last stages of the disease. It's not that they're overdrugged. It's not that they're being basically drugged to the point to where they cannot move or do anything. It's the disease. But when you do this and go in, you don't understand that. This is where a therapist can be a great help. A caregiver should understand that it is not where the care receiver is at. It is where the caregiver is at in terms of placement. If the caregiver has had it and can't take it anymore, then it is time to place, regardless of where the care receiver is in terms of the stages of the disease. A therapist really helped me to place my spouse and to understand why. I was working from home because I needed income to pay for the care. And she would constantly come into the office and engage in conversations, even when I was on a conference call. She was oblivious to the fact that I was working. She had progressed in the disease to where the person I married was not that person now. And the therapist would say to me that my wife was gone, that Nora was gone. I was beginning to enter the stage of guardian and leaving the stage of spouse. These are hard things. These are not easy. These are very difficult things to do. Placement is one of the hardest decisions to make or implement because it fundamentally changes the caregiver situation. The care receiver is no longer in the house. Generally, the care receiver is not coming home. They will pass in the memory care or medical facility. In other words, what the therapist told me was after I placed Nora, she's not coming home. Do not expect her to come home. So what should I do? The caregiver should have made non-negotiable criteria for placement in the early part of this journey. What do I mean by that? Non-negotiable criteria I learned when I was a manager in IT. Programmers who would do programs, they, for some reason or other, would have a unique relationship to the programs. It was almost like a child to a programmer on this. If we had a problem with a program that was affecting customers, I would ask the programmer to look at the problem and see if they could, one, define the problem, and number two, what a solution would be. And I said, how long will you think that would take? And they said, oh, about a half hour. So I would come back in a half hour and I'd say, how it's going. They say, well, I'm getting pretty close, but I need another half hour to deal with it and so forth. And I'd come back in a half hour and I say, well, how's it going? They say, well, you know, I'm almost there. I just almost got it. I need another half hour. And so I said to them, I said, finally, I'll give you one more half hour, but if you do not have the problem defined or a solution in progress, I'm going to bring other people to help you with the program on that. And so at the end of the third half hour, if they really were not working on the solution, I would bring other people in, and they understood that it was because of the criteria and not because I didn't think they did a good job or I didn't think of that. So when the diagnosis comes in, then there should be the caregiver at a minimum, and possibly if the care receiver is capable of the discussion, there should be a discussion of the non-negotiable criteria for placement. And my view is the non-negotiable criteria for placement is the caregiver's non-negotiable criteria. It's touchy involving the care receiver, as they may not really be capable of participating in the discussion. It may be part of the advanced directive discussion, or the receiver may be concerned about your future or your finances. My issue was incontinence. If Nora became incontinent, I was not going to change diapers. I could not be capable of dealing with diapers with my wife. And so if she became incontinent, to me, that was a non-negotiable criteria for placement. It didn't matter what stage she was in. I was not going to be capable of dealing with it. On that. Here are some of the behaviors that is not one that should not be acceptable or capable of tolerating. Violence, incontinence, mine, just too needy. This came up in support group. The person was so needy that it just overwhelmed the caregiver. Lack of sleep, because you're constantly got one eye open to make sure they don't get up and wander. Hostility. You get angry because they're asking the same things all the time. You get angry because they can't remember anything. You get angry because they can't go from A to B to C on that. You can't take it anymore. They're always there. This was another one that came up in support groups. No matter what I'm doing and no matter where I am, there she was standing next to me. She was always there. And it got to the point to where I couldn't stand it anymore on that. These are part of the non-negotiable criteria for placement. You'll notice that we're not talking about what stage is the person in. We're talking about your capability of providing care. And is it the best care possible? If I can't get myself to change diapers, is that the best care possible for Nora? No. Placing her in a facility where the people are trained to deal with incontinence and to deal with that. One time I visited Nora, and she had an accident, and they were actually giving her a shower to clean her up after an incontinence session on that. And that just reinforced my view that, boy, I couldn't deal with that. We have added ethical issues that you're going to be facing too. The coronavirus and how are they dealing with the coronavirus in the facility? Do I or don't I place the loved one on that? Because Nora's advanced directive said, do not prolong the process, even if the facility had an outbreak of coronavirus, I would have placed her on that. The facility, even before coronavirus, if one of the people in one of the pods got the flu, they would shut down the pod. They would basically lock the door of the pod so that no one could go in and out without assistance from a caregiver on that. And that's how they controlled communicable diseases in the facility. They would isolate them, lock it down so that no one could go in and out until the disease, in a sense, had run its course on that. Let's take some questions at this point.
Sure. From Susan, does a healthcare proxy that stipulates no resuscitation, no mechanical respiration, no feeding tubes, with the person stipulating they do want antibiotics and maximum pain relief, and living will give the same legal authority as an advanced directive? You better read it. It's kind of.
Yeah, well, that, let me deal with the legal issue. It's too bad that we couldn't ask that question with Loretta, but my view is the will and the power of attorney is more concerned about setting you up as the agent and allowing you to become the agent as it is in outlining exactly what the receiver would want to have happen given certain circumstances on that. Now, I know that some power of attorneys are quite detailed and others are not. I like the advanced directive as being the guiding instrument because it is specifically geared to end of life. It's specifically geared and deals with those issues rather than dealing with the issue of legal authority on that. It's basically saying, I want this person to speak for me when I cannot speak for myself, and here are the things that are important to me as I approach the end of life. And so I found the advanced directive to be a much better document and a much better exposition of what Nora wanted. Than she also had a medical power of attorney than the medical power of attorney did on that. So it was a better guide for me, and that's probably the best way that I can respond to that. Yeah.
Okay, thank you. From Luis, do you have anything else? No?
Mm-hmm.
Okay. What's the difference between a guardian and a power of attorney? My husband has power of attorney for his sister, who is in a memory care facility, and it seems he is doing a lot you described as a guardian. Are they interchangeable?
Okay, the problem here is the use of the word guardian. Guardian is a legal term for a legal situation to where you go to court and you become, in a sense, the guardian of the person, and you, in effect, are now capable of making decisions for that guardian, not necessarily speaking for them, but making decisions for them, decisions about healthcare, decisions about finances, and so forth. The guardian that I was referring to in the beginning of this piece was the role guardian, as opposed to the legal concept of guardian. That, for example, if you have a foster child and the foster child is living with you, in a way, you're a guardian because you're checking and making sure the person's fed, clothed, and so on in relation to it. It's not necessarily coming from the legal document, guardian or conservatorship. It is your role that you no longer are a spouse because there's no conversation going on. There's no give and take going on. You're really just making sure that the person is being fed, is clean, is clothed, and is not being abused, and so forth. So it's a role concept to me, not a legal concept of being able to control all aspects of the other person's life.
Thank you. The next one is from Ruth. Is it better for a person placed in a facility to never visit the home again?
My view was, because Nora didn't want to go, that I was not going to take Nora in and out of facility. So when I placed her, she did not come out on that. And I found that to be better for me, and in some respects, better for her, than to constantly take her in and out of the facility. From my viewpoint, in and out of the facility would have been very confusing for her and would have fed into her view that she didn't want to be there on that.
Okay. Thank you. That's it at this point.
Okay. Type of placement options. There's at-home care. This option may be the only one because the lack of resources or the ability to pay for a facility. In other words, I can't afford a facility. I have to take care of them in the home. All care is the responsibility of the caregiver. By that, I mean, they have to hire the caregiver. They have to supervise the caregiver. They have to pay the caregiver. They have to basically deal with the caregiver pretty much like a boss or a manager or a supervisor would in relation to it. Sometimes that is not an option for the people because they don't have the resources. The unfortunate part is that if you need a caregiver 24/7 on this, you're going to wind up probably more expensive for a caregiver in the home at 24/7 than a memory care facility on that. If you have the resources to pay for 24 care at home, then my view would be is it'd be better off to be a memory care facility for you. You would be better off if they were in a memory care facility. If you don't have the resources for 24/7 care, then in effect, you're going to fill in for a portion of that 24/7 care on that. Assisted living, in my opinion, is not really an option for placement. It may be an option for early stage of the disease, but generally the care is still the responsibility of the caregiver and assumes that there is rationality and that there is some understanding on the part of the person in the facility.
Bill, I'm sorry to interrupt you. Are you advancing your slides? Because we're kind of looking at the same slide.
Well, let me see.
Because I'm seeing ethical issues slide in my experience, and that's it.
Okay, I apologize. Let me stop sharing and pick up again. Thank you for the.
Sure, I didn't realize that you.
Is that up now?
Yes, placement and life after. Yeah, and I can see your cursor. Yes.
Okay. I really apologize for that. Okay. We talked about home care. We talked about assisted living a little bit. That, in my opinion, it's not really an option because assisted living assumes the person has some rationality, has the capability of doing some things for themselves. They're just needing assistance as opposed to real care in relation to it. My view is that if you go into assisted living, even in the early stages, you're going to wind up having to put them into a memory care facility because most assisted living facilities are not really structured or have the expertise to deal with a full memory care issue on that. Foster homes, this one is not easy. Many people like this approach because it feels like home. However, there are some major issues that come with foster homes. One, security, another is staffing, and the third is the expertise in memory care. A person in a support group placed their wife in a foster home. She didn't want to be there. She spent her whole time going outside and basically walking around the perimeter of the fence trying to find an opening. They did not have secure locks on the fence or in the house. And so they had to basically upgrade the fence in the house to provide security in relation to it. The interesting thing there is they charged him. He was responsible for the upgrade of these facilities because the foster home was not designed to deal with a person with memory care who would want her or want to leave. Staffing issues. Foster homes usually are run by a family or a small group of people. And if something happens to that person, say, for example, it's a small family and the husband or the mother dies, they may have to close the facility because they don't have the staffing capable of dealing with it. They may not have the financial backing necessary to have a full staffing portion of it. Second, or thirdly, is that graveyard shift, 12 midnight to 6 or 7 in the morning. If you have 6 or 7 or 8 people there and some are memory care and some are not, and there happens to be an emergency, how does one person or 2 people deal with that? How do they deal with those emergencies and so forth? Also, foster homes generally are not trained or professional in relation to taking care of people with memory care. They're really dealing with people who are elderly, who are disabled in some respects, physically, not mentally. And in a sense, there isn't a major assumption, just like in assisted living with foster homes, that these people are rational and that you can reason with them and you can talk to them and They will understand your instructions and so forth. A memory care facility is expensive. That's its biggest drawback. They're expert in dealing with people with memory care. They're secure facilities, and they're devoted to dementia patients. In a sense, a memory care facility, a person who goes there who has dementia is with many other people who have dementia. And in some respects, that's a positive. That's not a negative, because many times I would come to visit Nora and she'd be talking with someone there who also had the same issue she did. And although I could not understand what they were saying, I understood the words, but I didn't understand what they were saying. They were having a great time. They were enjoying themselves talking and so forth. And I have no idea what they were talking about or how they understood each other in relation to it. But she was in a social setting and was capable of being social in relation to it. The other thing is, and we talked about this, was Medicaid. Medicaid pays for memory care facilities, and it pays for 24/7 caregivers on that. So if you don't have the resources, you really need to go to an authority, a legal authority, and get yourself structured so that you can apply for Medicaid, because Medicaid will pay for these facilities on that. And in fact, that's about the only way that the insurance and government will pay for memory care is through Medicaid on that. Each one of these facilities, assisted living, foster homes, memory care, are all state, generally they're all state regulated. That's what the ombudsman structure is doing. The ombudsman structure is the one that goes into these facilities to ensure that state laws are being abided by, federal laws are being abided by, and that the people are not being abused and they're being taken care of and things are being properly done in relation to it. The at-home is not necessarily regulated. It's regulated and it may be audited by the state, but it's not, you have to have a complaint for the ombudsman to come in and basically review the situation in a home care. In memory care facilities and foster homes and assisted living, they can come in unannounced and have a visit to see how things are going. That's not necessarily the case with home care. Home care, you have to have a complaint or you have to request that they come in and take a look and see what's going on in relation to that. The other thing on a memory care facility, I wanted it to be corporate. I wanted a corporation, in a sense, to own the memory care facility. Now, I know that some of you think the corporation may be a bad word. From my perspective, what the corporation provided was institutional structure. It provided a process of maintaining the staff. It provided for turnover. It provided for training. And it was not dependent upon a person for the existence of the memory care facility. Consequently, it took care of some of the issues that foster homes would have in relation to it, because it was a corporate process. Here's a spreadsheet that I put together on placement. How do you evaluate a placement on this? How do you evaluate facilities? And I might add that you will get a copy of this spreadsheet when I send out the PowerPoint, separate from the PowerPoint, even though it's embedded in the PowerPoint. I send out a separate spreadsheet for that for your own purposes. Couple things. One is, placement one really is your requirements. What are your requirements for placement on that? In other words, when we go through these criteria, there's two things. One is, what do I want to see happen? And number two is, what does my partner, my husband, my wife, my son, my daughter, my mother, my father, how would they want, or how would they like this particular process? And again, placement is your decision. Placement is not their decision. They're not rational. By the time you get to placement, they are not rational. And when I went to place Nora, I did not talk with her about it. I did not bring her to any of the places that I reviewed. And I, in effect, the only time she saw the place was when I actually drove up to place her on that, because it was my decision, not hers. She wasn't capable of making that decision on that. And I know that that's another difficulty that you have to overcome, because a lot of people in their relationships with their parents and with their spouses is that it's a consensus. Let's agree on that we want to do these things. Well, at this point in time, this is not a consensus situation. Well, they will not understand. When you do a placement, again, I made the spreadsheet in a sense after the fact, not before the fact, because of what I learned in going through the tours. One is family involvement. Families are encouraged to participate in care planning. Are they encouraged? Are families informed of changes in residents' condition and care needs? Are families encouraged to communicate with the staff? When Nora would fall, for example, they would give me a call. No matter what time of day or night it was, they would give me a call and tell me that Nora fell, everything's fine, and but just to be aware that she had fallen on that. And that's where the families are informed of changes in residents' condition or care needs. Staffing is another major issue. Medical care is provided. Does the facility manage medicines, including ordering? Is there a doctor that has weekly or monthly visits? Do they accept private health insurance for medical care? Do they accept Medicare or Medicaid? Is there personal care and assistance provided? Does the staff recognize persons with dementia as unique individuals, and care is personalized to meet specific needs, abilities, and interests? Is the staff trained in dementia care? And are the number of staff on duty during graveyard? What's the number of staff on duty during graveyard? A couple things on this. One is that I was extremely happy about the fact that a doctor came and visited once a week. In fact, I transferred Nora's primary doctor to the doctor that visited the facility once a week. And what I found out was that the doctor is the one who would recommend whether a person go in to hospice or not. If you have to go and take your person out to a doctor visit, and the doctor visits are regular, once a month or once every 2 or 3 months and so forth, you may not be aware that there's changes in the behavior or in the medical condition of the person that would indicate they should be in hospice. The doctor in 2 of the 3 cases basically knew that the person should be in hospice before I was even aware that that should be the case. I know that not all facilities have doctors come and visit, but I found that to be extremely valuable and really highly recommend that that be the case on that. Programs and services. The appropriate services and programming based on specific health and behavioral care needs are available. Planned activities take place. Activities are available on weekends and during evenings. Activities are designed to meet specific needs and interests. And transportation is available for medical appointments and shopping if they are capable. And care planning sessions are held regularly. At Fern Gardens, which is now Table Rock Memory Care, we would meet every quarter, and I would meet with the management of the facility, and we would go over Nora's quarterly health report. How she did, what were the changes, was there anything they noticed that should be taken care of? Was there anything I noticed that I was concerned about? And so we had basically regular meetings on the care of Nora. I didn't just put her in there and walk away on it. The residents, when you take a tour, the personal care is done with respect and dignity. Are the residents comfortable and relaxed and involved in activities? Are the residents well groomed, cleaned, and dressed appropriately? And I want to add about dressed appropriately. That doesn't mean that the shirt and the pants and the socks all match. But memory care facilities to me are the closest you come to a commune. Nobody owns anything. They do not remember what they own. And so when I would buy clothes for Nora, for example, socks, I would buy 10 or 12 pairs of socks because I knew that they would wind up on other people besides Nora. I would see Nora in a blouse that wasn't hers. Other people might be wearing her clothes. Even though they would have name tags in the clothes and so forth, they would get mixed up. One time the facility, when I came to visit, gave me her wedding ring and said they found it on another person, and took it off that other person and gave it to me on that. And that's because if something is on a counter down, they don't know who owns it. They don't know if they own it. They don't know if the other person owns it. They just pick it up, and as far as they're concerned, they own it on that. So when you place a person, do not bring anything there that you would not want to be taken. One person in the support group brought a lot of his wife's jewelry to the facility, and some of the jewelry disappeared. Nobody knows what happened to the jewelry on that. So when you place, do not bring things of value that you want to keep on that, because again, nobody owns anything because they don't remember what they own on that. The environment, is the indoor space allow for freedom of movement and promotes independence? Indoor outdoor areas, are they safe and secure? Is the facility easy to navigate? Is there designation for family visiting area? Do the residents' rooms, are they clean and spacious? And the residents are allowed to keep familiar items with them, such as photos or bedding. And again, the caution. Things that you don't mind getting lost are probably what should be brought there on that. And again, these are you have to outline what your requirements are so that when you do your comparison, you know whether they're matching your requirements or not. Meals. There are regular meals and snack times. Is food appetizing? Is the dining environment pleasant? Are family and friends able to join at mealtime? Does the staff have a plan for monitoring adequate nutrition? Is the staff able to provide for special dietary needs? Is the staff provide appropriate assistance based on the person's abilities, such as spoon feeding? Are there no environmental distractions during mealtime, such as noisy TVs and so forth? Nora had a real problem with black pepper. Black pepper totally upset her system. And I was capable of telling the staff there that her food should not have pepper, and they accommodated. They were capable of creating her meals without black pepper on that. Those are the kinds of things that you need to ask them about. One place that I visited, the kitchen was out in the open, and the people who were there could walk right by the kitchen and be in the kitchen, so to speak. At Fern Gardens, the kitchen was sealed off. The people who were there as patients could not go into the kitchen. I preferred that mechanism rather than an open kitchen in relation to it, because at not too late a stage in the disease, a person really shouldn't be involved in the kitchen and shouldn't be involved with cooking or anything of that sort. So that was some of the things I learned in retrospect in relation to it. Policies and procedures. Do they require guardianship? When I placed Nora, they required guardianship. So I had to go to court and get guardianship to place her in the facility. Is the facility only for dementia residents, or is there a mixture? I would prefer that it all be dementia residents. Family and friends are able to participate in the care. Visiting hours work for the family. I found that at Fern Gardens, I could go at any time of day or night. But people who were not related to Nora, there were visiting hours during the day. Discharge policy has been discussed. Learning about the situation and condition that would lead to a discharge from a facility, such as a change in behavior or financial circumstances. What are the discharge possibilities of the facility? For example, at Fern Garden, if the person became violent and wasn't capable of being controlled, then they could ask you to leave on that. You need to know what are the conditions under which they could ask you to leave in relation to that. Cost. There's two basic models of costing that I found. One model was the bundled cost, which was Fern Gardens. In other words, I paid $4,900, and it included all levels of care, whether it was minimal or whether it was maximum in relation to it. There's other facilities that have what they call a monthly base rate. Maybe like, I'm going to make the figures up, but this is pretty much what it looks like. $3,000 a month is the base rate. And if you have level 1 care, which is minimal care, it might be $600. So you're going to pay $3,600. As the disease progresses and they need more care, then it may be another $600. So now you're paying $4,200 a month in relation to the care, because you're at level 2 care. And if you get to the final full-blown care, you may find yourself paying actually $4,800 to $5,400 for the facility as you get these levels of care. I did not particularly care for the levels of care. I wanted an omnibus bundled cost, so for budgeting purposes, because I didn't want the cost to increase over time, because my income was going to decrease over time. So I wanted to be able to have a fixed fee, so to speak, and understand that this is what I'm going to pay, and that's how much I'm going to pay on that for that. So additional costs may be for medicines, maybe doctor visits, maybe supplies, maybe special treatment, such as showers, baths, and so forth. On the bundled cost, I had to pay for the medicines, but they did the mail order and they would get the medicines. I would just get the bill. At the doctor visit that came every week, it was like a primary care physician. I would get a bill once a month. My medical insurance took care of the medicines and took care of the doctor visits on that. I would have to pay for the Depends, the diapers and so forth on the supplies on that. Those were in a sense, the extras that I had to pay for in relation to the bundled cost, but it didn't matter the level of care. I was paying one set fee. The facility that I was at accepted Medicare and Medicaid. And as I mentioned before, I was within at least 6 to 9 months of having to go into Medicaid. I would have basically ran out of resources on it. Does it accept private insurance, such as long-term care insurance? Does it accept private insurance for the medical costs? What is the ownership? Is it a consortium or is it a corporation, like I indicated, in terms of the financial soundness of the institution? And does it accept credit card electronic payments? Fern Gardens at the time didn't accept electronic payments. I had to pay them by check on that. What are the intangibles? During the tour, is there friendly, loving physical contact by staff towards residents, such as a pat on the back, touch on the shoulder? Do the residents know the person who's going around, and do they know the names and so forth? I visited 2 facilities in one sense. One was on one end of the spectrum, where the person walked me around on the facility. There were people there. The person who was walking me around never once talked to the people, never once called them by name. The people never talked to her. People never called her by name. It was as if they were in 2 separate worlds. When I went to Fern Gardens, the person taking me around knew everybody's name. She would say hello to the people would come back. One of them actually hugged her. And there was a relationship between the person taking the tour and the people in the facility. Obviously, I picked Fern Gardens in relation to it, but that's some of the things that you might want to look at on the tour as you're going through that. Does the person that is showing you around know the residents? and how long have they been in this location and in this business? In other words, how long has the memory care facility been in existence, and how long have they been in this location? There's a large need for memory care, and that has increased over time. And so a lot of places are going to be new, and they're going to be in the location for the first time. That's when, to me, you need to kind of look at the ownership. Who is it one person? Is it a consortium? Is it a corporation? Who owns it? And in a sense, who's behind this new process? And the last one was fire drills. If you have 50, 60, 75 people with dementia, and you have a fire in the place, how do they handle that? How do they deal with that? What is their response to a fire drill, or do they have fire drills, and so forth? And that's also a question you should have for foster homes. What do they do in emergencies, such as a fire or a tornado or things of that sort? How do they deal with that, and how do they deal with the people inside? Okay, before I go any further, let's deal with some questions.
Okay. Does it matter if the memory care center is for profit or non-profit? Does one seem better to you?
From my point of view, no. It's more in terms of how are the competency of the facility. And to me, the expertise of the people in the facility on that. If they want to make some money off of it, that's fine. If they're a nonprofit, that's fine. I'm more concerned about the care and the expertise in relation to it. Obviously, you don't want an exorbitant situation to where you're paying $5,000 a month and it looks like they're spending $1,000 a month on taking care of people. You don't want that particular circumstance. But I think that would be somewhat apparent in when you go through on your tour from the spreadsheet.
Okay, thank you. Next one. The contract we signed with my mom's memory care facility says that they can kick you out if they don't have an adequate staff resident ratio. If that happens, do we have any recourse?
The real answer is no. You don't have any recourse because I don't know why. Well, let me back up. If they don't have adequate staff, then the care is not going to be at a sufficient level to be, in my view, acceptable. Consequently, you're going to have to move them to another place to have adequate staff if they cannot fix that. The thing I was concerned about was that if somebody was violent, for example, and they couldn't control that violent person, were they capable of removing that person from the facility? And that's kind of what I was looking at in terms of being able to have somebody come up and say, well, you have to leave.
Right. Thank you. Okay, next one. Did the bundle cost go up every year to accommodate inflation?
Well, we were in a period where there was actually moderate inflation, almost no, very low inflation. The cost did go up, but it did not go up exorbitantly, and it didn't go up to what I would say too painful a process. It all appeared very rational in terms of the increase in cost on that. What happened was, because Nora didn't want to go, we put her in a single room, and that was $5,200, I think, a month. And then as the disease progressed, that became less of an issue. And so she then went into a shared room with another person, two-person room on that. And the cost dropped down to $4,900 or so on that. So, but given high inflation at this particular point in time, I'm sure that inflation is going to take place. But again, to me, the bundled price is better for budgeting and financial planning than if you have level of care, because if you go back to the plateaus, I don't know when the level of care changes. I don't know when she's going to require more care. So I can't really predict that in the fourth quarter, I'm going to have an increase in the level of care. It could come in the third quarter. It could come in the first quarter of the following year. I didn't know exactly when a level of care was going to be imposed. And that to me was a bigger problem than the annual increases in inflation.
Thank you. If you are going to show more slides, you accidentally opened your help menu within your PowerPoint. You can exit out. Look at the.
Yeah, I know. Problem is I've got no, let's go.
At the top.
Next question.
Yeah, that's it.
Okay. Added criteria in evaluating facilities. How do you handle coronavirus and use coronavirus as a sample of a pandemic? In other words, how do you handle when there is a pandemic? Like I mentioned before, in the facility that Nora was in, if someone in a pod had the flu or got a communicable disease, they would shut the pod down so that they would isolate that pod from the rest of the facility. And they would lock the door so that it was controlled entrance and exit on that. In a foster home, that may not be the case. You may not be able to really separate the people and so forth. So those are some of the things that you need to kind of take a look at. Are the caregivers properly protected? In other words, if they do have something like coronavirus, do they have personal protection equipment? Are they wearing masks? Are they doing the things? Do they have a vaccination program for the staff and so on? What are the visitation policies now? How do you place if they do not want to go? That was the case of Nora for me. She absolutely did not want to go. And that's part of the reason I did not talk to her about it. That's part of the reason I did not take her on tours. If I'd taken her on the tour where the person didn't talk to anybody and didn't know the names or anything, that would have been a killer as far as Nora was concerned. I did not want to even have to deal with rationalizing to Nora, oh, well, this is, don't worry about it, and so on. The way I got Nora there was I lied. I basically said that I have a business trip and you need 24/7 care, and I cannot find someone to come in 24/7 for my business trip just for a few days. But I did find a facility that would take you for 3 or 4 days, and I can go on my business trip and I'll come back and pick you up and we'll go home. And she begrudgingly said, okay, on that. And so when it came time to place her, I basically packed a suitcase because I was going to go away and took her to the facility. And when I got to the facility, I walked her through the front door. I talked to the manager, the caregiver came out and said, Nora, I want to show you some things. And Nora said, okay. And so she followed the caregiver through the secure door, and she was basically in the facility, and she was going to be shown where her room was. I did not go inside with her. I talked to the manager a little bit more, and then I left. And what I did is I went down to see friends on that. Remember this chart. This to me is when you're at the point where it's all about the receiver. Everything you do has to be rationalized against the receiver. Can I do this? Can I not do this? Can we do this? Can we not do this? And so forth. And so when you place a person, your job and your activity has to be to follow this arrow and go back out to outgoing, active, joining, highly social, and in terms of your needs on this. You have to reintegrate yourself into society on that, because you basically retreated from society because it's too difficult with the person with dementia. So as the disease progresses and you progress into the center, when you place her, you have to progress back out to the outer rings of Maslow's hierarchy of needs on this. And this is the process that hopefully will take place when you place her on that. When you place her, you need to go away, out of town for a week or two. You need to visit friends, relatives, etc. Why? One, you need to let the diagnosed adjust to their new surroundings. You need to, in a way, let them know that this is where they're staying. And you need to adjust to the new situation and also to understand how far involved you were in caregiving. This was really the recommendation of the management of the facility that I placed Nora. They said, go away for 2 weeks because this will allow her to adjust to the fact that she's living there and get her used to the routine. They get used to her, and she knows in a way that nothing's going to happen. She's not going to leave on that. I went down to visit friends in the Bay Area for two weeks. And what I found was after 2 or 3 days, which I was totally consumed with talking about placing Nora, much to the chagrin of my friends on that, after 2 or 3 days, we began to talk about other things. We began to talk about the world. We began to talk about the economy. We began to talk about each other and so on and so forth. And what I found on the way home and reflecting on that experience was I did not realize how far I was into caregiving, because that was the first real adult conversation I had had in months on that. And you don't understand that, and you don't really, you don't recognize it because in a way it's so gradual on that process. The other thing I realized too was that I was not abandoning Nora. She was in the best place possible for her care. She was getting better care than I could provide. And so in that respect, I had done my job. I was successful at caregiving because I put her in a situation to where she got the best care possible. The second thing that was also recommended to me and worked was make yourself not visit every day or have meals every day with them. Again, let the diagnosed adjust to their new situation and let you adjust to your new situation and begin to move out towards the outer rings of Maslow's hierarchy of needs. In other words, reintegrate yourself socially. If you're having dinner with them every day, you're not having dinner with friends. You're not reintegrating into society. It's still all about the receiver on that. The other thing too is by going away and not having meals with them or visiting them every day is they get familiar with their daily routine. They basically get plugged into a new routine that is comforting to them because routine is extremely important to them. The third thing you need to understand is that they are leaving you. You are not leaving them. The disease has taken them away from you. You have not left them. You have a life to live. You need to put yourself first, not them, after you placed. They are being cared for. In a sense, you are not. You are on your own. You need to reintegrate yourself into society. And you need to have physical contact with others without your spouse or partner. In other words, go back and think about sex on that. There is a lot of life to live. And so you have to be understanding your future is the rest of your life. They're being taken care of. The disease will take care of whatever's going to happen. There's nothing you can do about that. And so you need to focus on yourself. You need to look at yourself and say, okay, there's a lot of life left. I might point out that in the support group, 2 or 3 people basically got married. One got married, they were in the same support group. He placed his wife, she passed in 4 months. She placed her husband, he passed in a year. And the 2 got together and they were married, starting basically another segment of their life. Okay, let's take the last set of questions.
I don't see any more questions, but Susan, do you still have a question? Yeah, go ahead and mute yourself.
Yes, this is maybe impossible for you to answer. I'm the lady who's my mother. I live in Virginia. My mother lives in New York in the house I grew up in. She's very, very independent, very headstrong person. And I have a person coming a couple times a week and a cleaner coming every other week. But, you know, her dementia is moderate. It's progressing, but slowly. She's very lucky it's slow. She's 85, but eventually she's in good physical health. So eventually she's going to have to go somewhere. I ideally would like her to be out by us, but I don't know how to get her here.
I'm sorry to chuckle a little bit, but it reminded me of the fact that I lied.
Right. I mean, it's one thing to lie and take them 15 minutes away. It's another to lie and it's a 5-hour drive or, you know.
Yeah, but it's possible to do that. You could tell them that we're going to visit some friends that may be mutual friends and so forth. And this is where we're going to go. We're going to spend the weekend or something like that with them. And then you could bring them down in relation to it. The real issue is, and this is where the difficulty comes in, and this is why it's so hard. It's your decision, not theirs. They're not rational.
Right.
They're not going to make the good choice. And so in a way, you have to really wrestle with yourself to say, okay, I'm just going to decide it and we'll work it out.
The problem for me is she won't be the same person she is now, of course. You know, this is she's told me before when I wanted to hire people, I won't answer the door. And I know her, she won't do it. I may have mentioned her caregiver came and we were there at the time and the caregiver couldn't bring her car that day. And we needed our car because we were going someplace. And the caregiver went outside to take out the cat litter and my mother locked her out while we were there. She was mad. And just to get her in the car, she remembers coming out here to do rehab for 30 days. And she, you know, was furious. She acted like we threw her a bag over her head and put her in the car, but she needed someplace to be and she actually didn't want to stay with us. So, and she didn't want to be in New York. So she's very tough. So I'm just concerned at how I will actually be able to make the move at the time, but that's maybe just too much to predict because she won't have the same memories and skill sets that she has now.
Well, I think you have to be aware of the second level of denial and also be aware, and I noticed this in the support group, that we make decisions, and I wasn't immune from this, and we make decisions sometimes to avoid conflict. And even when it should be the right decision to make. One suggestion might be is you might work out placing her up there rather than down there, at least in the beginning.
Yeah.
And
that may have to be.
And that way, then it is a 15-minute drive and so forth. The other thing too is talk with the caregiver that comes in. Pull the caregiver aside and talk with the caregiver about the situation. But it sounds to me, and I'm going to be harsh, and please don't hold it against me, she should be placed.
At this point?
Yes.
Wow, okay.
Because she's going to do harm to herself.
Yeah. And when you say second level of denial, I remember you discussed that. Would that be on my part? Is that the denial?
Yes. You are giving her more credit for being rational and being capable of taking care of herself than I think she really is.
Well, the incident I relayed to you about the locking the lady out, she was that kind of mother to me even when I was a child. So that's actually not atypical.
No, I understand, but it's still not a
Sadly.
good, it's not a good thing for her right now, given her situation.
I think she would just be so wild. She has a proclivity to collect feral cats. She has one in the house, 2 outside. That's like her. She goes to her senior center 5 days a week, and she has her feral cat inside with this cat. But I'm getting into a lot of details now. And
Yeah, but I would talk to the caregiver and talk to the caregiver about her situation. And if the caregiver is only coming in a couple times a week, she's not getting 24/7 care. And so that could be a problem. I know that, Michelle, you have something?
Oh, hello. I was just going to say,
thank you.
Susan and everybody, Bill, you are so right. What I found is that sometimes with my patients, I would work with the families and get the person in who needed care. They may not be totally ready for it, but essentially I would say, Mrs. Jones, you need to help work with your daughter to get placement now. You need to pick where you want to go, because if it gets too bad, they're going to yank you out of your house. Adult Protective Services will come in and you will not have a choice. So when you've got the opportunity to make that choice, you may want to do it. Sometimes it worked, sometimes it didn't. If it gets too bad, sometimes you can get Adult Protective Services involved, depending on where you're at and where the state is.
Or you find that the police find the person walking down the road by themselves, not knowing where they are.
Exactly. Thank you.
These are tough. This is tough. Placement is one of the hardest things to do because it alters everything. It makes you feel bad. It removes the person, and it puts you into a completely different kind of situation and role. And these are tough transitions to make. But you have to rely on the fact that if you place them, you're doing the right thing. You're actually providing better care for them than you can provide. Are there any other questions?
I would like to read the comment in the chat because I think it's from everybody. Thank you. This has been so valuable. I appreciate your generosity in helping others, even at the cost of having to relieve your own painful experience. And I think that's sums it up.
Well, thank you very much. Now, when I send out the PowerPoint, to close up here, when I send out the PowerPoint, I'm going to send out the PowerPoint, I'm going to send out the spreadsheet, and I'm going to send out a evaluation form. And what I'd like is, if you want to, I'd like you to email it back. I'll send it out with my email address, obviously. But if you could send it back to me, I would appreciate it. It will help me to improve the class and make the class even better. And secondly, if you want to be anonymous, I will include my address and you can just fill out the application and mail it to me. And that way, if you want to make, for lack of a better term, insensitive comments, you can be anonymous and mail it to me. And so I won't know who did that. But again, I appreciate the feedback. I would like to improve the class. And so let me know what can be better. Let me know what was successful. And I really want to thank all of you for attending the class. I want to thank all the people that I don't see who are on the streaming portion of it. And I want to thank also the people who view this through YouTube. I'm happy to do this because I would like people to have a better experience than I had.
Thank you, Bill. Thank you so much.